Today I'll be talking about something that we don't necessarily think about all the time, but wanted to talk about cardiovascular health within the lens of exposomics. So I have no disclosures, no financial disclosures, but I do have academic disclosures. I'm interested in environmental health and environmental justice and climate health, which is probably one of the main issues that is going to face all of us in the next decades, in the next century. So one of the things that we don't necessarily talk about all the time, we know that cardiovascular disease is the main cause, major cause of morbidity and mortality in the world. But what we don't talk about all the time is approximately 1/3 of cardiovascular disease we don't actually know, what is the cause. We think that it's environmental and occupational risk, and that's what epidemiologic studies have been attributed to. We know that environmental factors have been estimated to cause approximately 9 million deaths annually in the world. And so there is a compelling need to really understand what is the measure of all the exposures in a lifetime. From the moment the person is conceived, not even before they're born, but also throughout their lifetime and until they die. So every year, every so often actually, the American Heart Association comes up with this something called life essentials. And life essentials are some things that we need to characterize cardiovascular health and how do we optimize cardiovascular health. And these are usually the things that are intuitive. So normalizing cholesterol, controlling your blood pressure, do not smoke, and so on and so forth. These are basic things. And this year, in 2022, actually, last year, they had introduced this concept of really social determinants of health as major contributors to cardiovascular disease. And this is something that we need to address going forward. But I would go a step further and I say that the exposome is actually what's important. Just beyond just regular social determinants of health, beyond your income, beyond your occupation, beyond your employment, there is this concept of the personal exposome, which includes your diet, physical activity, work in chemicals that you're exposed to, but there's also the external exposome, and this is all the exposures that you're exposed to in your neighborhood and in your work. So think about air pollution, think about temperature, think about green space, think about noise, and so on and so forth. And how do these interact with each other to kind of cause and result in biologic responses to the exposures that you're exposed to? And this is what we measure. This whole conference was talking about microbiome, gene expression, epigenetics, and metabolomics. But all of the above have been really linked with the entire exposure, right? Exposome. So if you look at the global burden of disease study, and this comes out every few years, this is an epidemiological study that looks at the entire kind of world and see what are the causes of death and what are the attributable causes of death. And you can see here that total pollution or environmental pollution causes approximately 9 million deaths. And this is if you take a look at everything that we talk about today and every day, AIDS, alcohol abuse, accidents, drug abuse, Ebola, all of the above have, if you add them up all together, they don't come up to the 9 million deaths that the total pollution affects. So this is a huge issue, especially in low middle income countries. We have studied air pollution for a long, long time, right? So air pollution now, this is almost like a meta-analysis, so to speak. It's an exposure concentration kind of relationship with an effect of mortality or cardiovascular disease. And you can see the effect, as far as we know so far, it's a curvilinear relationship. The PM concentration on the x-axis and the relative risk of the cardiovascular disease on the y-axis, and you can see that when we, as concentration of PM per particulate matter, which is the main air pollutant, increases, the relative risk of cardiovascular disease increases. We also show you the WHO standards and the US standards. Most of the United States lives above the new WHO standards, but you can look at the countries where 60s and 70s. This is where a normal day in India and in New Delhi, for example, a normal day in New Delhi goes up to 60, 70, 100, while in the US, our levels are in Houston approximately 7 to 10. In other parts of the country, they're even lower. So we started as a cardiologist. I am still interested in looking at what is the impact of air pollution as part of my career as what is the impact of air pollution on patients who have pre-existing cardiovascular disease. So we took the extremist kind of conditions, which is patients who have end-stage heart failure who are going for heart transplant. And we linked, this is a national study that we linked to air pollution measures using zip codes. And you can see there's a linear relationship between particulate matter on the left side with the hazard ratio for cardiovascular disease. And when there is an editorial that accompanied this paper that looked at how does the relationship change if you're looking at a primary prevention cohort, which is basically patients who are healthier compared with patients who have pre-existing cardiovascular disease. And it shows that the hazard ratio, for example, for patients who are healthy is 1.09, suggestive of low risk compared with a severely higher kind of hazard ratio, which is 1.26 for patients who have cardiac transplant. So this tells us that our patients who have cardiovascular disease that we see in clinic every day, they're even more susceptible to air pollution levels. But these are patients who are living in the United States where the levels are extremely low. Still, despite adjusting for all the cardiovascular risk factors, you see a 26% increase in if you live in Houston compared with if you live in Puerto Rico, for example. Same thing applies to patients who have pre-existing atherosclerosis. These are patients who are going for stenting. This is a study that we looked in the Veteran Affairs hospitals, which is a national kind of health system. And you can see that if you have a stent at 50 and you're exposed to a slightly higher risk of air pollution, this is, again, all within the United States, you lose 2 years of your life, right? So this is even at the low levels of exposure that we experience in the United States, we see exposure level, we see impact on health in the United States, specifically for patients who have pre-existing cardiovascular disease. But it's not only air pollution, which I spoke about, but there's this new development of emerging evidence to suggest that noise, even noise that you're experiencing at your work, on the way to work, at home, it leads to significant increase in cardiovascular disease. So you can see the pathways here. I'm not going to go through them, but there is a lot of evidence from both animal studies and human studies to suggest that there is enos uncoupling. There is a lot of downstream effects, including hypertension, arrhythmias, and diabetes that have been linked to noise exposure. And this is a recent study that looked at the UK Biobank, which is a very large cohort, and showed that closeness, proximity to traffic noise is associated with incident hypertension, elevated high blood pressure. In addition, there is high temperature and low temperature. They're both associated with significant increase in cardiovascular morbidity and mortality. So you can see here, this is what we've been experiencing over the past 2 decades, 3 decades. From the 1990s till now, you see a significant increase in number of deaths and disability-adjusted life years, which is a measure of morbidity from cardiovascular disease, both from increased high temperatures and low temperatures. And as intuitively known, you can see that the high temperatures are mostly in Africa, and the low temperatures are mostly in Russia and the Alaska region. So when I see patients in clinic, I have been, all my life I've been studying the heart, and Karam and I and John, we study the heart, and we study everything in the medical school and residency and fellowship. We study the heart and how do the arteries look like, how the myocardium looks like. And now we started to think about, okay, what are some of the factors that affect heart disease? The sugar levels, the blood pressure levels, the physical activity, the sleep, and so on and so forth. More recently, in the past couple of years, we started to think about, okay, if a patient has a myocardial infarction or a stroke, we started to think, okay, even after we adjust, even after we control blood pressure, we control weight, control cholesterol, there's still high risk for having events in the future, another heart attack. So people started to think about residual thrombotic risk, and this is clotting, that happens despite controlling these things. And now we have randomized controlled trials that show that controlling the thrombotic risk can actually lead to reduction in heart attack risk. People are also started to think about residual inflammatory risk. So, controlling inflammation using IL-1 beta, antibodies, IL-6 antibodies. You can see that there is a reduction of cardiovascular events downstream. But what I would advocate for is really studying the residual social risk and the residual environmental risk. And these are things that we don't necessarily think about. And although I draw them here as part of an outer circle, they really impact every component of the figure, right? You can see that residual environmental risk, residual social risk, they really impact blood pressure. They impact physical activity, they impact your sleep, they impact your cholesterol and glycemia for sure. So one of the things that we try to understand is geographically, we wanted to use a data-driven approach to understand cardiovascular disease. And if you look at a map of the United States and look at the premature cardiovascular mortality, you see there is a significant distribution. It's about 5 to 6-fold difference between the highest county and the lowest county. And this is premature cardiovascular mortality before 65 years of age. But we started to we started to link every county in the United States. This is more than 1 million patients who died from cardiovascular disease before the age of 65. We started to link them with a lot of different kind of exposures. And this is going back to the concept of the exposome. So people have thought about median household income, poverty, but we started to think about air pollution, the race composition of the zip code, the PM 2.5, which is another metric of air pollution, physical inactivity percentage, and so on and so forth. So using random forest analysis, which is one type of a machine learning method, you can see that we can start to identify what are some of the factors that are contributing to the geographic distribution or the differences in the variance in cardiovascular mortality. And it's not surprising to see that median household income comes up in the top, but you can start to see that broadband access, internet access, becomes an important metric here. Insufficient sleep becomes one of the top 10. Receipt of SNAP benefits, which is food stamps, is an important thing. And then you can start using additional methods to actually try to tease out what we call decision trees, so you can identify what are some of the risk factors that are associated and what is the importance of each risk factor so you can try to target it. And you can see that we identified phenotypes of counties throughout the United States. They're not necessarily geographically confined to certain areas, but they're all over the place, but they have a common shared kind of fingerprint or exposomic fingerprint. The other thing that we have a cohort of patients in Cleveland, Ohio, where we've done CT calcium scores for. These are CT low-dose CTs where we can identify the amount of atherosclerosis in the coronary arteries. And we said, okay, let's ask a simple question. Let's link everybody who lives in Northeast Ohio with a variety of different kind of exposures. So we took every patient, we geocoded them to where they live, into longitude and latitude, and we linked them with 155, every individual with 155 kind of census tract exposures. This is social, environment, built environment, natural environment. Think about everything, light, noise, temperature, everything that under the sun. And then we started to cluster those. So these are the figures that you've seen in genomics and so on and so forth. This is a heat map looking at the clustering of the individuals at the level of their neighborhood. So we identified in an unbiased fashion, we identified three clusters of neighborhood, cluster 1, 2, and 3. And then we started to look at where those patients live, and it's not very clear to us where these are urban versus suburban. There's the cluster 1 looks like it's an urban, but there's a significant portion that's on the east side, and the southwest side is also suburban. So it's not something that you can just geographically put a circle around and you can say, okay, if you live in this area, you're high risk. But when we started to look into the downstream impact or the association of these maps, you can see the rate of major adverse cardiovascular events, including stroke and heart attacks, it's very different depending on some of these clusters. And even after you adjust for calcium score, which is really one of the major causes, anything you adjust for calcium score goes away in the model. Here we see that there is some of the clusters are associated with increased risk for myocardial infarction and heart failure, and the risk is really not small. We're talking about 60 to 80% residual risk of cardiovascular disease, while some of the clusters are associated with a stroke. Another approach that we started to take and start to really quantify, the challenge with understanding the exposome is really how do we quantify the exposome. So one of the things that we started to think about is remote sensing. So how can we look at Google Street images, for example, that are available, or Google satellite images that are available throughout the world, and try to understand and come up with the new metrics for social determinants of health and geographic determinants of health. So here you can see what we do is we identify kind of images from the Google Street View images on the lower side and from satellite images. We run them through a deep learning model, which can classify these images in an unbiased fashion to look at features within the image. For example, how much green space there is, how much tree space, how much, what is the pavement looking like, and so on and so forth. And then we do some regression. And here, when we started doing this exercise, I thought, okay, let's look into the coronary artery disease risk and the prevalence of coronary artery disease. I thought that we can explain probably 20 to 30% of the variance in coronary disease. So here what you see on this figure on the left lower corner, on the x-axis you see the actual coronary heart disease prevalence, and this is in 7 cities. So each dot here is a neighborhood. And on the y-axis you see the estimated coronary heart disease prevalence using just the images. The software is looking at the images and identifying is this image associated with high prevalence or low prevalence. And you can see that the R-square here is approximately 0.64, suggesting that approximately 64% of the variance in cardiovascular disease prevalence is explained just by looking at where you live, picture of your home from outside. And these are the maps that you can see the observed on the left side, satellite predicted and street view predicted images are almost very similar. But there is some technique in machine learning called attention mapping. So attention mapping allows us to look at what is type of the image, what is in the image that the software is looking at to identify features that are associated with increased coronary disease risk. And you can see that the software, in an unbiased fashion, is identifying this very kind of unpaved road, and it looks like it's a rural area that is associated with increased risk of coronary disease, while the lower part of the picture looks like a nice house. And it's highlighting not just the nice house, but it's highlighting the green space that's associated with lower risk of coronary disease. When you take this and take it into individual patients, you can see that you can come up with a Google satellite image derived score for risk. So we took the same about 50,000 patients, and you can see after adjusting for a lot of different things, a quartile 4 of, there's a linear relationship between GSI or Google Street Image derived risk score with the risk of heart attacks and strokes down the road. That risk actually is different by the calcium score. So if you have no calcification, if you have no atherosclerosis in your heart, the risk is more steep. The higher the GSI risk score, Google Street Satellite Image risk score, the higher the relationship. And you can see the line is very steep here. And this is despite adjusting for GSI, despite adjusting for calcium score, despite adjusting for even social vulnerability index, which is a metric of about 16 different socioeconomic status metrics. But how do we take this back to the clinic? The problem is we've noticed that if you look at prediction, and which is the hallmark of prevention in cardiovascular disease, we need to identify good, accurate, precise prediction of risk, because that's how we prescribe medications to patients. Medications can be costly. They have a lot of, we have different medications that we can do. And how do we choose which patient receives what medication? Depends on their downstream risk. So we really need to identify risk in an accurate fashion. It turns out that the risk scores that we utilize in clinic these days, they depend on your lipid, your blood pressure, your weight, and so on and so forth. They don't really capture the social risk. They don't capture the environmental risk that you live in. And it turns out where you live matters for these things. And this is something that's available in Epic, in the EMR system, but we don't actually use it because we don't know how to interpret a zip code. So if you look at here on this is a calibration plot, which basically tells you what is the observed relationship between what we predict using a risk score called WatchDM. This is risk for heart failure. What is the observed on the y-axis versus the predicted on the x-axis. And you can see, if you look at the line in the black, you can see that if you live in a quintile 1 of social deprivation index, which means that you're living in a rich area, good, higher socioeconomic position, the model overestimates the risk. While if you live in a quintile 5, which is a high social deprivation or low socioeconomic position, the model underestimates the risk significantly. So how can we recalibrate this model? And you can see in red now we recalibrated the model using what you look for. So this is basically the conceptual framework, is we can actually take risk calculators and we can look into social and environmental determinants of risk to identify what is and refine the risk that we utilize from cardiovascular disease. And we came up with an online tool that you can actually put your zip code in. This is the first online tool that includes a zip code. And basically the zip code gets recalculated into one of the social determinants metrics, and you can see that it gives you a refined risk score. So just to give you an example, in this zip code, which is a poor East Cleveland zip code, You can see the model estimates the risk approximately 18% in 5 years. But if you incorporate the zip code information, then you can get a 22.8%, 23%. So there's significant upstream, upscaling, uprisking. So how do we use this? What is the kind of conceptual framework to understand this? This is basically when we have exposome, which we talked about, but we have to incorporate what are the mechanisms that link the exposome with cardiovascular disease. And this includes all the tools that we spoke about today, genomics, epigenomics, transcriptomics, and that helps us understand some of the pathways, because one of the main questions is how does social determinants of health impact cardiovascular disease or any non-communicable disease for that matter. So this is what I propose. I propose basically using, similar to what Dr. Nasir was talking about a conceptual kind of cohorts that let us understand in deep phenotyping of an individual using wearables, radiomics, genomics, enviromics, and sociomics, and all the omics in the world. But we include them in a real-time spatiotemporal models. And these have to be in a data, AI, kind of data-driven fashion. But it helps us identify, first of all, if it's real time, it helps us identify early warning system. So if air pollution that day is high and the temperature is high, then we can identify that you really need to go to the hospital or stay indoor or do something, right? Same thing for early personalized intervention, because we can start to prevent myocardial infarction. We can start to prevent strokes that are associated with this. And then real-time resource allocation. If we feel that Houston is humid in this day, and then there will be more MI, maybe we can bring more cardiologists to be. So in summary, we know that although we think that they're responsible for significant CVD burden, environmental determinants are poorly understood. The concept of environmental exposome allows conceptual frameworks to understand cardiovascular and residual disease, and also understanding the residual environmental risk is important in the management of cardiovascular disease, and data sciences approaches can enable integration of big data. And like Dr. Nasir said, social and environmentally refined risk can improve risk prediction. I would like to thank my wife and kids, because most of that research has been funded by them. It's all time taken away from them. But acknowledge my collaborators and my research funding.